Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. For decades, we've been told that salt is our enemy. The less sodium, the better. But how good is the evidence? This is the People's Pharmacy with Terry and Joe Graydon.
Without sodium, our cells can't function. When sodium levels get too low, doctors call the condition hyponatremia. It's a life-threatening situation. How much sodium is enough and how much is too much? Researchers have been arguing that question for a long time.
A new study shows that inflammation plays a key role in heart disease. We'll find out how reducing inflammation can lower the risks of heart attacks, strokes, lung cancer, gout, and even arthritis.
Coming up on the People's Pharmacy, your questions and stories about the health news that matters to you.
First, this news.
In the People's Pharmacy health headlines, whole grains have a reputation as a mainstay of a healthy diet. The old food pyramid was built on a foundation of whole grains. But how good is the evidence that eating brown rice, steel-cut oats, or whole wheat bread can actually promote heart health? To answer that question, independent reviewers for the Cochrane collaboration analyzed 9 studies comparing whole grain and refined grain consumption. These were randomized controlled trials with a total of 1,414 participants. Unfortunately, none of the studies demonstrated clear benefits on blood pressure, cholesterol, or cardiovascular complications. The authors concluded there is insufficient evidence from randomized controlled trials of an effect of whole grains on cardiovascular outcomes or on major cardiovascular disease risk factors such as blood lipids and blood pressure. That's not to say that eating whole grains is pointless. It's just that the studies don't show whether it provides any benefit.
Scientists investigating a possible link between magnesium levels and dementia report an interesting observation. People with both high and low levels of magnesium in their bodies may be more susceptible to cognitive decline. The research included 9,569 older adults without mental impairment. They were tested for their levels of magnesium and followed up for approximately 8 years. The investigators identified 823 people who developed dementia during the study. Those with the highest magnesium levels, as well as the lowest, were 30% more likely than people with moderate amounts of magnesium in their system to be diagnosed with intellectual decline. The researchers emphasized that this link does not demonstrate a causal role for magnesium levels, only an association.
What accounts for differences in blood pressure? A new analysis from the National Heart, Lung, and Blood Institute Working Group suggests that the ecology of bacteria in our digestive tracts may play a significant role. In animals, changes in the ratio of the intestinal bacteria Firmicutes and Bacteroidetes are linked to elevated blood pressure. Bacteria in the mouth also make a difference. Some organisms can help produce nitric oxide from nitrate-rich foods. Nitric oxide helps relax blood vessels and lowers blood pressure. When those microbes are missing, the result may be less nitric oxide in circulation and higher blood pressure as a result. Antiseptic mouthwash may wipe out some of these nitric oxide-producing organisms and create an imbalance in the microbiome.
It's estimated that 1 in 8 Americans takes an antidepressant medication. Such drugs affect neurotransmitters like serotonin. Most people assume that medications like fluoxetine, paroxetine, and sertraline are very safe. They also think that these drugs only affect the brain to ease depression or anxiety. But serotonin is found throughout the body and plays an important but little understood role in many physiological processes. A new study suggests that antidepressants may not be as innocuous as they seem. Researchers conducted a meta-analysis of 17 studies comparing people using antidepressants to those on placebo. They found that those taking antidepressants were 33% more likely to die during the study time frame and 14% more likely to have a heart attack, stroke, or other cardiovascular event. People who already had cardiovascular disease, however, were at no higher risk if they took an antidepressant. The type of antidepressant did not seem to make a difference. These findings appear to suggest that doctors and patients need to evaluate benefits and risks for antidepressants just as they do for other medications.
People who undergo chemotherapy for cancer often experience nerve damage as a complication. This peripheral neuropathy is manifested as numbness and tingling, pain, or cold sensitivity. A study from Roswell Park Cancer Institute suggests that women taking multivitamins before or during treatment for breast cancer are less prone to this complication. The nutritional supplements reduced the likelihood of serious neuropathy by almost 40%. No specific vitamin or mineral was identified as responsible for the protection. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon. I'm a pharmacologist.
And I'm Terry Graydon. I'm a medical anthropologist. Today we're talking about the health news that matters to you. Do you get confused when the experts disagree about what you should do to stay healthy? Coming up, we'll tackle one of the more controversial topics in nutrition policy. How much salt should you eat? Should you toss the salt shaker? We'll also take your calls about saturated fat and whole grains.
But first, we want to bring you up to date on a study published in this week's New England Journal of Medicine about the role of inflammation in heart disease and other common conditions. We're talking with Dr. Paul Ridker. He's the Eugene Braunwald Professor of Medicine at Harvard Medical School and Director of the Center for Cardiovascular Disease Prevention. He's the primary investigator of the CANTOS trial.
Welcome back to the People's Pharmacy, Dr. Paul Ridker.
It's a pleasure to be back with you again.
How long has it been since the Jupiter trial, Dr. Ridker? That's when we talked to you the last time.
Well, that was published in November of 2008. Our studies tend to take a long time to get done, but it's really a pleasure to chat with you again about where things have moved since then.
Well, that was a landmark study because something called high-sensitivity CRP, C-reactive protein, was a risk factor for heart disease. Now you have a new study, and it's really quite extraordinary because we've thought for decades that, cholesterol, that was the name of the game. If you had high cholesterol, you were prime target for a heart attack.
And what you needed to do was lower it.
But what you've shown is that there's another factor, and that's inflammation, and that just lowering inflammation can make a big difference. Can you explain the CANTOS trial, please?
Sure. It's very exciting data, and it really is a major step from where we've been. Let's remember, though, for your listeners, we still want to get cholesterol low. In fact, everybody in this trial had their cholesterols low taking high doses of statin-type drugs. So that's still correct. But the fact is that a lot of people have what we call residual inflammatory risk, not residual cholesterol risk. And the reason they're at such high risk for a second heart attack, a second stroke, perhaps dying a cardiovascular death, is because their inflammation is simply too high, and that inflammation is measured with that high-sensitivity CRP test that you just mentioned. So CANTOS took a very unusual perspective. We randomized over 10,000 patients across the world who'd had a prior heart attack, already treated with the usual aggressive things that we as cardiologists do, including statin therapy. And then we said, if we lower the inflammation with a unique drug, a drug called Canakinumab, we can come back to, but have no effect on cholesterol at all, might we see further vascular benefit? And that's a big question because it really challenges dogma, but it also asks, what else can we do out there to prevent this disease?
What did you find?
Well, the CANTOS trial showed a 15% reduction in ever having another heart attack, stroke, or cardiovascular death, and about a 17% reduction in having those events or needing to come into the hospital urgently for some kind of a revascularization procedure in the absence of lowering cholesterol. And the reason that's so interesting to us cardiologists is that's the exact same magnitude of effect that was seen earlier this year with a class of drugs called PCSK9 inhibitors that are pure cholesterol lowering and have no inflammation effects. So what we've seen here is that there's another way of lowering cardiovascular risk. The second thing we saw was about a 30% reduction ever needing bypass surgery or an angioplasty. Now, that's a big deal clinically for my patients who obviously don't want these procedures. It's also important for sort of cost effectiveness, thinking about what we can do to prevent disease. And the third piece, which I think for many people outside the research arena was a bit of a surprise, was our data on lung cancer. Lung cancer is a disease that's also driven by an overactive inflammatory system in the sense that certain tumors progress in what's called an inflammatory tumor microenvironment. That's a complicated word, but it basically boils down to the fact that the patients who got this novel drug, Canakinumab, they had over a 50% reduction in all-cause cancer death and about a 75% reduction in incident lung cancers. So that's a nice cherry on top to the heart disease part that really was driving the clinical trial.
It certainly is. My question to you, Dr. Ridker, is where is all this inflammation coming from?
Well, it's a great question. Part of the inflammation has to do with our lifestyle issues. So I tell my patients, if you've got a high CRP, if you diet, exercise, and stop smoking, what I call the mom and pop part of preventive cardiology, that will help across the board. Some of this, unfortunately, is on a genetic basis. Many of our patients have a more pro-inflammatory response than do others. So it's a combination of what our parents gave us and what we've elected to do with our lifestyle.
When you talk about diet, a lot of people think back a couple of decades to you're not supposed to eat butter, you should eat margarine, which of course was loaded with trans fats. There are a number of other foods that have been substituted for fat that are high in sugar. And we've been hearing lately that trans fats are a problem. Of course, sugar and refined carbs may be a problem when it comes to inflammation. So is there an anti-inflammatory diet?
Well, there's a lot of buzz about the potential for such an anti-inflammatory diet. I should tell you that the data are a little mixed. I think that this is about discretion. Certainly, a more vegetarian-based diet is known to bring down the CRP levels, and of course, also leads to a more healthy outcomes across a number of endpoints. Whether there's a specific anti-inflammatory diet, we could have a long debate about.
Dr. Ridker, you mentioned the medication that you tested in the CANTOS trial is something called Canakinumab. What the heck is it?
So Canakinumab is a bit of a mouthful. It's a drug that is called a therapeutic monoclonal antibody. So this is a drug that functions kind of like an antibody that binds a very, very specific target, something called interleukin-1 beta. Now, what is that? That's a critical factor that drives this underlying inflammatory response that many patients are quite well aware of, even if they've never heard of these terms. Think about gout. Gout is a disease that leads to a very painful, swollen joint in the big toe or your thumb. That is an inflammatory response that if you give this drug, Canakinumab, you can really shut down. And the question was, could we take this scalpel-like anti-inflammatory intervention and reduce cardiovascular event rates? But we have to be a bit careful here. This is a very targeted anti-inflammatory type drug. It's not like taking ibuprofen or Motrin or aspirin or Vioxx. Those are very different inflammatory pathways. So the only evidence we have to date is for this very specific target known as Canakinumab. But I should tell you, I'm running a large clinical trial funded by the U.S. government, the National Heart, Lung, and Blood Institute, and we're using a very inexpensive generic drug that you're quite familiar with. That's low-dose methotrexate. This is the drug taken by millions of Americans to treat their rheumatoid arthritis, but we're actually giving that anti-inflammatory drug not to patients with arthritis, but to patients who have had a prior heart attack. That study has about 2 more years to go.
Wow. That is really cool because it is very affordable and has been used for a very long time.
Not just for rheumatoid arthritis, also for psoriasis.
And for cancer in higher doses. So that's a really interesting new development. I do have one follow-up question, and that is there was an unexpected finding that you mentioned, and that was a lower risk of lung cancer, a pretty substantial lower risk. And that leads me to the idea that inflammation seems to be at the heart of a lot of chronic conditions, not just cancer, but perhaps diabetes, perhaps Alzheimer's disease. I mean, many conditions are traced back to inflammation. I'm wondering if there are strategies that may lower inflammation. Of course, we've heard that aspirin is not just good against heart disease, but possibly against cancer as well, like methotrexate or aspirin, that might lower inflammation generally and lower the risk of some of these chronic conditions.
Well, you're raising a very important issue. The real breakthrough in this CANTOS trial is that without lowering cholesterol, but by driving a particular pathway of inflammation down, we now have proven the inflammatory hypothesis of atherosclerosis. We now know that there's another way to lower heart attack and stroke that's not only based on the cholesterol reduction. But you're thinking very broadly, and that's a great way to think. In our CANTOS trial, we saw a number of other beneficial effects. I noted the effect on lung cancer because it's so striking and so important to our patients, although I should say the first thing you really should do is just stop smoking. That would be a much better thing to do. But we had a reduction in new cases of arthritis being diagnosed during this 5-year trial. We had a reduction in cases of gout during this 5-year trial. We actually had a reduction in cases of osteoarthritis, which most people think of as a wear and tear disease, but this data makes crystal clear, must have an inflammatory component to it. So you're right. We treat whole patients. We don't just treat organs. And in this clinical trial, we saw benefit across 5 or 6 different endpoints. We should be careful here, though. We also saw some hazard. That hazard was expected. When you give a drug that inhibits this innate immune response, you expect to see some increase in infections, and we did see that. So just like patients who might have rheumatoid arthritis and a physician might prescribe Enbrel or a TNF inhibitor and the risk of infection goes up, that also happened here. So patients and their physicians considering this kind of therapy have to think about, what do I do if I get an early fever or an infection? I have to get on antibiotics a little bit earlier. But it's important to recognize the hazards as well as the benefits.
Dr. Paul Ridker, thank you so much for talking with us on the People's Pharmacy today.
It's an absolute pleasure.
You've been listening to Dr. Paul Ridker, lead investigator of the CANTOS trial, which tested the inflammation hypothesis for atherosclerosis. Dr. Ridker is the Eugene Braunwald Professor of Medicine at Harvard Medical School and Director of the Center for Cardiovascular Disease Prevention at Brigham and Women's Hospital.
We have a link to his article in this week's New England Journal of Medicine. After the break, we'll talk about salt.
We'll also find out how science is changing on saturated fat.
Our lines are open for you at 888-472-3366. If they're full, just email us radio@peoplespharmacy.com. That number again, 888-472-3366.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. 800-345-7339. Online at uttercream.com.
If you'd like to purchase a CD of this show, you can call 800-732-2334. Today's show is $1,095, or visit our website. It's peoplespharmacy.com.
How do you feel when the experts change their recommendations of what you should be doing? If there's one shift in particular that bothers you, tell us about it. 888-472-3366. Or send us an email, radio@peoplespharmacy.com. You can also reach us through Twitter. We're at People's Pharmacy.
Again, that number, 888-472-3366. You know, Terry, for years we've been told that salt is bad for our health. The American Heart Association recommends that an ideal limit of sodium under 1,500 milligrams a day is the way that we should all be striving for, but there are a few medical dissenters. We spoke with Dr. James D. Nicolantonio, a cardiovascular research scientist at St. Luke Mid-American Heart Institute in Kansas City, Missouri. His book is The Salt Fix.
Welcome to the People's Pharmacy, Dr. D. Nicolantonio.
Thanks for having me.
You have written a really intriguing article with some colleagues in the American Journal of Medicine titled, "Is Salt a Culprit or an Innocent Bystander in Hypertension?" The subtitle is "A Hypothesis Challenging the Ancient Paradigm." I have to tell you, there are an awful lot of people who believe in their hearts that salt causes hypertension. And if you just cut back on sodium, you can get it down to normal, or at least close. Why is that hypothesis or theory wrong?
Yeah, so basically the body can handle at least 10 times the normal salt intake. So there's been studies that have given people up to 86 grams of salt per day. What ends up happening is the kidneys, they just freely filter the salt. The hard work on the kidneys is having to actively reabsorb the 3.5 pounds of salt that they filter every day. And so if we eat 10 times the normal salt intake, the kidneys can just freely let that pass in the urine with no increase in blood pressure. And that's been documented in clinical studies. And even giving 10 times a normal salt intake, even for several days, has not shown a clinically significant increase in blood pressure because, again, the kidneys will just let pass the salt that they don't need. The problem becomes when people start over-consuming refined carbohydrates and sugar, and their insulin levels elevate, causing the kidneys to over-retain salt. So what my book kind of explains is that cut the sugar, and you can a lot of times fix the salt-sensitive, quote-unquote, high blood pressure.
So, Dr. D. Nicolantonio, you're saying that salt doesn't cause high blood pressure?
There's never been any definitive proof that a low-salt diet prevents high blood pressure. And in fact, even when the recommendations came out in 1977, the Surgeons General in 1980 admitted that there was no actual definitive evidence of this. And so most of our dietary recommendations stem from those 1977 dietary goals, and there were no systematic reviews and meta-analyses of clinical studies to back up those recommendations. Unfortunately, those recommendations got integrated into the 1980 United States Dietary Guidelines, which got updated every 5 years, and the low-salt advice followed suit. And so there was never really any real proof that a low-salt diet prevents high blood pressure or cardiovascular events. And really, most of the studies show that people who are consuming the lowest amounts of salt are actually at the highest risk of cardiovascular events.
Whoa, wait a minute. Hold your horses. How is it possible that a low-salt diet, sodium restriction, could cause cardiovascular problems? A lot of people are going to find that a hard pill to swallow.
Yeah, so salt is an essential mineral. And so when you consciously restrict salt intake, several things happen. We know that aldosterone and renin, which are two artery-stiffening hormones, basically triple. Also, all the stress hormones, noradrenaline and adrenaline, significantly increase. When you cut your salt intake, a recent Cochrane meta-analysis of 170 clinical studies showed that cholesterol goes up, LDL, the bad cholesterol, goes up, HDL, the good cholesterol, goes down, triglycerides go up, and low-salt diets have been shown to cause insulin resistance and significantly increase the fat-storing hormone insulin. And so we've hyper-focused on blood pressure, and what my book kind of explains is all the harms that happen when we cut our salt intake, which I just sort of covered in a brief moment there.
So you say low salt diet affects insulin? How does that work?
So basically, insulin is a hormone that not only stores fat, but it helps the kidneys retain more salt. And so when you cut your salt intake, the body's response is to hold on to more salt. And one of the ways it does that is by making the body insulin resistant to raised insulin levels to help the kidneys retain more salt. And so that's just one unintended consequence of consciously restricting this essential mineral.
Now, could you help us better understand what is, quote unquote, the normal sodium intake across the world? Because the recommendations by the American Heart Association, less than 1,500 milligrams of sodium a day, is very restrictive and pretty hard to achieve. So help us understand what people are actually doing versus what the American Heart Association is encouraging us to do.
Sure. So 50% of people are consciously trying to follow this advice, and 25% are being told by their doctors to try and follow this salt-restrictive advice. And so they're trying. So there's certain days where they absolutely may not ingest much salt at all because they're trying to follow the guidelines. But, one of the body's safety mechanisms is to increase salt cravings when you are deficient. And so the reason that that happens is because it is an essential mineral and our body controls its intake. Otherwise, we could potentially die of salt deficiency. And this is why we know when animals are deficient in salt, they somehow know to go to a salt lick because the brain's reward system activates for salt. So what most people end up consuming is between 3,000 and 6,000 milligrams of sodium, which is 1 1/3 teaspoon of salt, and 2 2/3 teaspoons of salt. So 95% of the world's population on a chronic daily basis is probably consuming that amount of salt, and that's exactly where we see the lowest risk of cardiovascular events and early death.
So what would you say to the American Heart Association if you got to sit down in front of their expert panel?
Well, we know that that advice is only based really on the DASH sodium study, only based on blood pressure, not on hard endpoints. And so we have these two set intakes, recommended intakes for salt. The 1,500 milligrams and the 2,300 milligrams is our upper level of intake, only based on blood pressure, mainly because in the DASH sodium study, that's where blood pressure reductions were found. If people restricted their salt intake to 2,300 milligrams, and there was even greater reductions in blood pressure at 1,500 milligrams. I would tell the American Heart Association that even though there was a reduction in blood pressure, that could just mean dehydration. And we know that because heart rate increases in almost anybody who cuts their salt intake. And so just a reduction in blood pressure does not necessarily mean this will lead to a reduction in cardiovascular events. But there were harms that actually happened during that trial. So in the DASH sodium study, the patient population that was put on the low-salt diet, even though they had a reduction in blood pressure, they had a significant increase in the total cholesterol to HDL ratio, which is a more predictive marker of heart disease than even LDL. And there were also increases in triglycerides, and there was reductions in HDL. So we can't just say that blood pressure supersedes all these other surrogate markers and just assume that it is a good reduction in blood pressure and not potentially just dehydrating someone.
Dr. DiNicolantonio, we have been told that some people are salt sensitive and that they need to cut back on salt. Are there people who are salt sensitive, and what should they be doing?
Yeah, there's definitely people who are salt sensitive, but don't blame the salt for what the sugar did. Over-consuming refined carbs and sugar is well documented in the literature to cause insulin resistance and elevations in insulin levels, which can cause an over-retention of salt. And so even giving people metformin has been shown to fix salt-sensitive blood pressure because you're fixing the underlying cause of the high blood pressure, the insulin resistance, which does happen to cause an over-retention of salt with the elevated insulin levels. There's also other disease states like high aldosterone levels, high cortisol levels, and even Liddle syndrome, which is extremely rare, which causes the body to over-retain salt. But we can fix those syndromes by giving medications like spironolactone to reduce aldosterone levels, or some people may have an aldosterone-secreting tumor. But why take away the one substance that can allow people to eat healthy? Why tell them to consciously restrict salt when we can fix the underlying issue? Even in people who are salt-sensitive, it's really not the salt that's the problem. There's some underlying effect causing that person to not tolerate normal intakes of salt.
And that is?
Well, One is high cortisol levels, which can cause an over-retention of salt, or a Cushing's type syndrome, but we can fix that with medications or surgery. And same thing with high aldosterone levels. We can fix that with medications or surgery. And same thing with Little syndrome. We can give people medications like amiloride and fix that actual underlying cause. Fix the underlying cause. Don't tell someone to consciously restrict an essential mineral.
And it turns out that the culprit from your perspective is sugar, not salt.
Well, if we're just referring to the two white crystals, absolutely. Salt has been blamed for a lot of the harms that actually sugar does. And so when we chronically consume sugar, we have a chronic increase in insulin levels, which can activate the sympathetic nervous system, which has been shown. I mean, we've had meta-analyses confirm that the increases in blood pressure by consuming a diet high in sugar are at least twice that of what we would find with a diet high in salt. And so absolutely sugar seems to be a much worse culprit than salt ever was.
And of course, frequently in processed foods, they go together.
Exactly.
What do you recommend our listeners do for a healthy diet?
I recommend people do not consciously restrict their salt intake because the body controls salt intake. There was a case study published in JAMA in the 1940s where one child was consuming a lot of salt, and to the point where their parents actually hospitalized the patient. And the doctors would find this little child, he was a toddler, raiding the cabinets for salt. They actually strapped him down to a hospital bed, and he ended up dying of salt-wasting nephropathy. And so that's what, if you see someone eating a lot of salt, it's probably the body telling that person that they need salt. And so to consciously restrict your salt intake can lead to severe negative consequences like dehydration and heat stroke and other things. And we should be listening to those salt cravings.
Is it true that there are some people whose blood pressure goes up when they cut back on sodium?
Yes, those are called reverse responders. And so the evidence shows that about 15% of people with normal blood pressure will have a significant increase in blood pressure of about 7 millimeters of mercury if they cut their salt intake. And that's because they're overactivating the renin-angiotensin-aldosterone system. And so it leads to blood vessel constriction and chronic elevations in blood pressure when they cut their salt intake.
And what are the complications of low salt, something called hyponatremia?
Yeah, so actually the main symptoms of low salt is actually dehydration and dizziness upon standing too quickly from a seated position, and also muscle cramps and spasms. But in certain people, they will absolutely have low sodium levels in the blood, and that can actually be fatal.
Dr. James DiNicolantonio, thank you so much for talking with us on the People's Pharmacy today.
Thanks so much for having me.
You've been listening to Dr. James DiNicolantonio, author of The Salt Fix. He is a cardiovascular research scientist at St. Luke Mid-American Heart Institute in Kansas City, Missouri. And you will find a link to his article in the American Journal of Medicine from our website soon.
How are you dealing with the confusion over salt or saturated fat or whole grains or inflammation? We just have a few minutes to take your calls at 888-472-3366. Email us, radio@peoplespharmacy.com, or via Twitter. We're at People's Pharmacy. Again, if you'd like to join the conversation, the number to call to share your pet peeve about medical reversals, 888-472-3366.
Now, Joe, Dr. DiNicolantonio mentioned that the problem with salt restriction is the evidence. It isn't necessarily that it's terrible to moderate your salt intake. It's that there's no good evidence that it's going to be good for you, right?
Well, that seems to be part of the problem, and that same problem is true with whole grains.
Exactly.
We've been told for decades that whole grains are good for you. The food pyramid had whole grains at the bottom. That was, what you were supposed to consume in massive quantities, but...
Well, and that is part of almost every recommendation about how to follow a healthy diet, eat lots of whole grains. But the Cochrane collaboration looked at randomized controlled trials that compared people who were assigned to eat whole grains and people who were assigned to eat refined carbohydrates, refined grains. no evidence of difference.
Now, I have to tell you, this is definitely a man bites dog story, because we have been told, as I said, that whole grains are absolutely the best thing that we should be eating. What is the Cochrane collaboration, and why should we believe them when they say there's no good evidence that whole grains are good for you?
Well, the Cochrane collaboration is a group of independent volunteers who analyze medical studies to see how good they are. And they have very strict criteria that they use, and they look at these things very, very carefully. And they only found 9 studies that actually compared whole grains versus refined grains. Those 9 studies included a total of 1,400 people and did not show that eating whole grains would really lower your blood pressure, your cholesterol, or your risk of cardiovascular complications, which of course is the most important thing. Although 1,400 people is not very many people to see a cardiovascular complication.
Right. Well, let's go to the phones, Terry. I believe John in Kansas City, Missouri is first up. Let's find out what John has to say. He probably is not a happy camper. What's up, John?
Yes. Hello, Joe and Terry. This is John, actually on the highway towards Kansas City from western Kansas.
Okay.
I'm on my way for a 3D MRI, but what I wanted to speak to was 20 or 30 years ago, my wife was told by our physician that not only did salt make her retain sugar, but retain fluid, but so did sugar, which would be a very direct, simple way that the blood pressure would be affected in the body.
And did she cut back on sugar?
Yes.
And did it make a difference?
When she was in her stroke rehab at Menorah, she was the only one on the floor that didn't have diabetes.
Well, that's really interesting.
Yeah.
Obviously her physician was way ahead of the curve by suggesting that she get rid of the carbs. The sodium, obviously, very controversial. Some people do retain fluids when they consume sodium. And so we're not going to suggest that everybody should consume massive quantities of salt.
It's pretty clear that eating way too much salt is also bad for you. So let's moderate.
Absolutely. When we come back, share your frustration about medical reversals. The number is 888-472-3366. You can email us, radio@peoplespharmacy.com, or via Twitter. We're at People's Pharmacy. Again, the phone number to join the conversation about medical reversals, whether it's sodium or whether it's whole grains. 888-472-3366.
You're listening to the People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel utterly soft and smooth. 800-345-7339. The website is uttercream.com.
If you'd like to purchase a CD of this show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1095, or visit our website. It's peoplespharmacy.com.
Today we're talking about the health news that matters to you. We've discussed the importance of inflammation in the development of cardiovascular disease. Inflammation should probably be counted along with cholesterol as a key driver of atherosclerosis and, no doubt, many other chronic conditions as well. Are there anti-inflammatory foods or dietary supplements that could be helpful? Or what should you avoid?
We've also discussed the possibility that recommendations on salt intake may change, although the American Heart Association is very slow to moderate its position.
And then there's the changing story on saturated fat. A recent epidemiological study, they called it PURE, found that the people who ate the most saturated fat were the least likely to suffer a stroke.
And PURE stands for Prospective Urban Rural Epidemiology. There were 135,000 people involved over 7 years. And what they found was that people who ate diets high in fat were actually less likely to have died than the people who ate foods that were low in fat. And, of course, there's that Cochrane collaboration recent review on whole grains.
Whole grains. You know, we think that whole grains are probably good for us, but the evidence still isn't quite there.
So is there a recommendation that's changed that has you perplexed? Perhaps there's an axiom you've always heard and wondered if there's any evidence for it. Well, tell us about it. 888-472-3366 is the number to call. And we'd love to have you email us, radio@peoplespharmacy.com.
And we go to Maggie in Georgia. Welcome to the People's Pharmacy, Maggie. Your question.
Good morning. How are you?
We're doing well. What's your story?
So I have Crohn's disease. I was diagnosed about 6 or 7 years ago. However, I suffered from childhood all through adulthood before I was finally diagnosed. And I've recently had a new flare-up dating back to 2015, really atypical swelling all throughout the body, lots of joint inflammation, constipation. Been trying to figure it out since 2016 with my GI doctor. They've referred me to rheumatologist, and nothing seems to be working. And I go out into the internet and try to find dietary, suggestions to see if that will cut the inflammation out in my body. And there's just a sea of information. I don't know, some of it's contradictory. And then I don't get the support and the help from my medical doctors because that's just not something that they seem to be too educated on or interested in. And so I kind of feel like I'm lost at sea trying to figure this out. And so I cut out wheat for a little while, didn't see much of a difference. I'm cutting out dairy now to see if that will help. And I just don't feel like I have a lot of guidance, and it's very frustrating.
Oh, I can hear that frustration and really appreciate it. Because, Joe, when you're dealing with something as serious as Crohn's disease, if your medical team is really not on board with helping you figure out how to manage the day-to-day, it's going to be very tough.
It is. And as you point out, this is a very serious health condition, and the internet has all sorts of weird information on it, including on our site. We talk about coconut macaroon cookies. Remember that story?
Yes, I do. For controlling the diarrhea that sometimes accompanies Crohn's.
And there is no science to support that
Absolutely
either. So
none.
It requires good communication with your health professionals, finding people who will listen to you, work with you on the diet. And there is probably no one simple solution. And we wish you well. Thank you very much for the call. Terry, we've got an email. This one comes from, I don't have a name, but she says, I'm fed up with medical flip-flops, whether it's hormone replacement therapy, calcium supplements, eggs, or salt. First, we're told one thing, then doctors change their minds. In the meantime, we consumers are left wondering what to believe and whom to trust. I'm still baffled by whether salt is as bad as I've always been told. And if you believe Dr. Nicolo Antonio,
maybe not. And we've got another email, Joe, from Jim in Winchester, Virginia. He says, I think new contradictory health information is exciting. It reflects new technology and long-term studies on humans. With the emphasis on evidence-based medicine, we need to accumulate more and more evidence. I don't hear anyone recommending a 1940s black desk telephone over a new iPhone, so we should embrace the iPhone-era medical knowledge and advice. Thank you, Jim.
Let's go to Binghamton, New York. And Nancy, welcome to the People's Pharmacy. What's your question or story, please?
Hi, Joe and Terry. So I am thin. My BMI is 21.
Wow, that's great.
Yeah, I exercise every day. I try to eat low sugar, no refined carbs, very little meat and dairy. And I have high levels of cardio-CRP. My cardio-CRP is high. And I just wanted to know what my next step was. If there's anything else I can do.
What did you say is high?
My cardio-CRP, the high sensitivity.
The CRP, C-reactive protein.
C-reactive protein is a measure of inflammation. It's not the only measure, but it's certainly a key one.
Have any of your doctors ever told you, Nancy, why your CRP seems to be so high?
Well, I'm in the medical field. I'm actually in endocrinology. I'm a nurse practitioner. And nobody can tell me.
Well, what Dr. Ridker suggested is there are factors, of course, exercise, smoking, all of that, but he also said genes.
Well, and another thing that may be relevant is microbiota. What we're learning, we used to think, especially in the early part of the 20th century when nutrition science was new and people were very excited about it, they pretty much figured that humans were a lot like laboratory animals, and each human was a lot like every other human. And so we could figure out exactly how much vitamin C you'd need to keep from getting scurvy, and that would be the amount of vitamin C you'd need. It's not very much, actually. But it turns out that as we get into the 21st century, we begin to appreciate more and more exactly how different each of us is, not only in our genes, but also epigenetically. And some of that is driven by the microbes that we host. And some of that may actually account for your high C-reactive protein. I don't know.
And that brings up the question of the anti-inflammatory diet. Dr. Ricker was a little dismissive. It was like, well, we just don't have a lot of evidence, and that may be true. But there are foods that are better able to lower inflammation than other foods. So we know that the refined carbs and the sugar and the juices, they're probably not such a good thing for you.
They presumably drive inflammation up, whereas whole vegetables and fish presumably drive inflammation down a little bit.
And olive oil.
Right.
So I guess the answer is, Nancy?
The answer is we don't have an answer, Nancy, but we'll keep on looking.
And keep testing your CRP to see whether, the exercise and the diet might make a difference.
Yes, I hope so. It's been high for over 2 years. I'm just worried it could lead to cancer or something else.
We completely understand. And, it's so interesting. We heard about the dietary methotrexate in low doses, maybe aspirin in low doses, have anti-inflammatory activities that can lead to benefits.
And perhaps for someone like Nancy, a low dose of aspirin, she'd want to talk to her healthcare providers about that.
Absolutely. There are benefits and risks of everything. Terry, let's go to Marvin in Charlotte, North Carolina, please, and find out what is on his mind. Hi, Marvin. Welcome to the People's Pharmacy.
Hello, my name is Marvin Francisco. Hello, Joe and Terry.
What's up?
I'm not a doctor, and this is in reference to the medical doctor that was discussing a little earlier about salt intake and sodium. And he seemed to be very forward with promoting medications on salt and sodium, when a lot of the things and diseases that we deal with in today's society are due to lack of physical activity and poor nutrition. And I think that the medical industry should be more apt to adapt or try to encourage people to be more physically active and fix their nutrition versus just doping them up and giving them drugs.
Oh, you put that so elegantly, Marvin.
I thought it was rather blunt myself.
I think that I don't think you're going to find anyone arguing with you about the value of maintaining physical activity. That clearly is very helpful. And to the extent that we can, I think every one of us should be doing physical activity every day.
But when it comes to nutrition, Terry, there is so much controversy, and that is where people their hair goes on fire.
Well, exactly. And it is very complicated. Human beings are complicated creatures, and there's a lot of things that can affect our well-being, psychosocial things as well as nutritional and physical activity things.
Well, just go in the supermarket and you will see all that low-fat dairy stuff, right?
Yeah, absolutely.
And, there's starting to be some full-fat yogurt, for example, and people are starting to contemplate full-fat milk and maybe even put cream in their coffee. Oh, my goodness, what a sinful thing.
Well, don't put any sugar in that coffee.
But a little cream, maybe that's okay.
Yeah, it might be.
Do you have another email?
I do. I've got an email from Melissa who says, after eggs not doing quite what we thought they did, and oatmeal not being quite as wonderful as we thought, and butter not being as bad as we thought, and margarine, supposed to be good but turning out bad. Well, after all those oops, I'm just not paying any attention to nutritional recommendations. And that, I think, would be a shame.
I'm afraid that kind of U-turn might be counterproductive. I got an email from Sue. I, too, am frustrated by the changing dietary guidelines. I've decided to mostly ignore them and eat more whole foods and reduce consumption of processed foods. I feel that Mother Nature knows what she's doing. And, I can't disagree with Sue at all when it comes to that. What did Pollan say? Pollan? Do I have the right name?
Yeah, Michael Pollan.
Michael Pollan?
Yes, he did. He said, eat food, not too much, mostly plants. And, it's not very specific advice. It might not even be purely evidence-based, but it does sound like really good common sense. And keep in mind that when he says food, he means actual food rather than engineered and produced and highly processed things to eat.
Exactly. Let's go back to Kansas City and talk to John. Hi, John. Welcome to the People's Pharmacy. What's on your mind?
Hello, John Terry. This time I will be speaking to the fat issue, and particularly to dehydrogenation that we've known since the 50s is bad for the arteries. And we've been substituting lately palm oil to help solidify things as a vegetable saturated fat, and now the industries, the big guys, are hydrogenating that, which I find rather alarming and ironic. Speaking to the egg and the cholesterol issue, we've known since the 50s that methionine in the eggs helps the body utilize the cholesterol. So.
Well, John, thanks so much for calling back. We really appreciate it. And Joe, eggs.
Well, we now know that eggs are okay, that eating eggs doesn't have a negative effect on your heart health, that, yes, they are full of cholesterol, but dietary cholesterol is not necessarily that bad for you.
Right.
888-472-3366 is the number to call if you want to talk about whole grains, saturated fat, eggs, salt, whatever's on your mind. Medical reversals is the topic today. Again, 888-472-3366.
And Joe K. emailed to say, I stopped eating grains about 30 years ago and I do just fine without them. Fruit, nuts, sunflower seeds, vegetables, and meat, mostly fish and chicken, fill my nutritional needs just fine.
Well, excellent. I have to tell you that this saturated fat story does have people really on edge.
Well, and John mentioned palm kernel oil, which is highly saturated. It is being substituted into many of the processed foods. I would say if you run into a processed food that is using palm kernel oil, you probably shouldn't be eating that kind of processed food anyway, huh?
Right. Now, we talked about what we called the PURE study, the Prospective Urban Rural Epidemiology Study that involved 135,000 people. But oftentimes it's criticized because it's epidemiology. It's not a randomized controlled trial. Well, there was such a trial, the Minnesota Coronary Experiment. It randomized 9,000 patients to get either saturated fat, which was popular back in those days, or unsaturated, the idea that they would get corn oil and it lowered cholesterol. The outcome was unexpected. People actually did better on the saturated fat diet, and that was a randomized controlled trial.
It was, and those results were not published right away. It took years before they came out. Joe, we have an email from Susan in Lost Hollow, West Virginia. She's responding to Nancy, and she's saying, I'm wondering if Nancy might try curcumin from turmeric, useful in reducing her systemic inflammation. And Susan points out that one of our guests last year, that would be Dr. A.J. Goyle, recommended BCM 95 as a highly bioavailable, good formulation of curcumin.
And we're just about out of time. We have messages from Alex in Myrtle Beach, South Carolina, saying that baby food recommendations have changed in the last month, and quite a bit, in fact. And so we're reducing the amount of sugar and starch that babies are consuming. We also have a recommendation that, whole grains are for the fiber, and that fiber is good for you.
Yes, and we do believe that fiber is good for us, but we're still looking for that evidence, eh?
Yeah. Well, that's all the time we have. Thank you so much for listening to The People's Pharmacy.
Lynn Siegel produced today's show. Kimani Hall provided technical assistance. Al Wadarski is the engineer, and Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1095. The number again, 800-732-2334, online at peoplespharmacy.com.
And when you go to the site, you can subscribe to the free podcast of our show, subscribe to our free email newsletter. If you do listen to the podcast, we'd be grateful for a review. You can friend us on Facebook, and at our site, you can also find information on prescription drugs, herbs, and home remedies, not to mention links to all the articles we discussed.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.